We know that physical therapy is going to be the best way to be able to get over whatever it is that you're going through, right?
100%.
So if you can't do that physical therapy because you're in such severe pain, how do you get to do that?
Yeah.
That's where you want to think about an epidural steroid injection, because the epidural steroid injection is not the answer. So my name is Michael Bottros. I'm the clinical operations chief and a medical director for pain services at the Keck School of Medicine of USC. I'm a clinical professor of anesthesiology. I'm also the fellowship director for the pain medicine program and the chair of the opioid stewardship committee.
I'm Alex Chen. I am also one of the faculty here at Keck, assistant professor in the department, clinical professor in the Department of Anesthesia, and practice both pain medicine as well as anesthesiology. And I also help out a little bit with the medical school in advising rising medical students when they decide to pursue anesthesiology as a residency. So one of the questions here is, what's one thing you wish every patient knew before walking to a pain clinic?
I think it's really important that there's some unfortunate misconception that pain management equals opioid medications, which is an unfortunate situation. And I think it's really because there's a lack of education, even in medical school, as well as, in the public eye, about what pain management is, what do pain physicians do. And it's kind of unfortunate because it works both ways. There are patients who come into a pain management clinic because they're looking for opioids. Unfortunately, they may have been started on an opioid by their primary care physician because, obviously they have good intentions. They want to help the patient that's in pain. Might not necessarily be the best option at that time. And so they find that the opioid's helpful and they just want me to continue it, which is not really what we try to do. We want what's in the best interest long-term for the patient. So I have to spend some time educating the patient about, what it is that we do. Because if the patient really just needed an opioid, they could have just continued getting the opioid from the person who prescribed it from the beginning. The whole point of coming to me is because I've spent many years in specialty training to try to get you pain relief, but without the opioid, right? So we have a lot of different ways of doing it, whether it's non-opioid medications, whether it's procedures, whether it's pain psychology that we have in our group, right? So that whole multidisciplinary pain management strategy, that's the best way. On the flip side, I think it's really unfortunate that there are some people who don't want to go see a pain management doctor because they think that's all we do is prescribe an opioid. So they end up not coming in to see us or kind of being dragged in to see us by a family member because they're in such severe pain and they really don't know what to do. And they have, again, the misconception that all we do is prescribe an opioid pain medication, which is not, I'm not necessarily saying that we won't, and just we have to determine if it's the right thing. But it's unfortunate because that's all they think that we do. And so they don't want to see a pain management doctor. And they don't realize when I start talking about, we could do this or we could do that. There's this procedure or there's this other type of medication. And they're really surprised. Yeah. And they're like, wow, I had no idea. I wish I would have come in earlier instead of suffering all this time. So it works both ways, unfortunately. Yeah. I just kind of wish that people knew just the amount of stuff we had at our fingertips that would be able to help patients who otherwise had no other option.
I totally agree. And I would say that conversation happens in my clinic probably every day where, a patient goes, I didn't know this was an option. And I always respond to them, I don't think it's the patient's fault because like you said, you hit the nail on the head. Even in medical education, we were talking about this earlier, I think in the year where in medical education, we don't really have a lot of time dedicated to pain management. And I think part of the reason why I went into pain was, when patients say something hurts, they kind of care more about it. And it's not that these other chronic diseases like diabetes or hypertension aren't important. They're extremely important. But I think patients put them off because they don't feel it, right? Feel the effects of it until it's too late. But when something hurts, they'll say, ow, that hurts. And then, what do we do about it? And I think pain management is a great avenue to at least explore, again, other options, right? Other more targeted therapies, perhaps, or more multimodal therapies. I agree. I think it's something, not just the patient, lack of perhaps the public understanding what we do, but even also I had to be critical of our own field of doctors and of healthcare professionals as well.
We talk about medical education and how much time is spent teaching other doctors about pain management. There was a study that came out in 2011 that tried to survey all the North American medical schools, the United States and Canada. And they found that in the 4 years of medical school, in the United States, they spent an average of 9.5 hours of their total medical school curriculum on pain management. In Canada, it was a little bit more. I think it was like 19 hours on average. But if you look at the total number of hours of education in medical school, that equates to about 0.03% of the time spent on pain management for like the thing that would probably bring a patient most likely to see a doctor is pain.
To figure out what's going on.
Exactly.
Right? Yeah.
Let's put that into context. Veterinarian schools spend 500 times more amount of curriculum time teaching veterinarians how to treat pain in animals than medical schools teach doctors how to treat pain in human beings.
Yeah.
And then we ask ourselves why we're in the situation that
Yeah.
we're in with opioids and everything.
Yeah.
It's pretty sad.
Yeah.
Yeah.
But yeah, I think that's why we do what we do, to at least be an outlet and be an avenue for
Yeah.
you know, hopefully for patients that feel that we can be of assistance, and other doctors obviously too, if we can help assist as well.
Exactly. Yeah. Absolutely. So, Dr. Chen, why is back pain such a common issue? And how has the approach to treating it evolved over the years?
I've asked this myself a lot, you know, why is the back such a, why is it always back pain, right? And back pain's probably one of, if not the most common diagnosis that patients probably, forget pain doctors, just go see their primary care doctor for. You know, I've kind of tried to take a step back and try to take a 10,000 foot view of this. If you think about it, you just think about the back as a structure, right? That's there to keep you upright. But keeping you upright is if you think about it, a very difficult thing to do. And with all the little bones that work together to comprise your back, and all the joints that articulate with one another to allow you to bend, twist, it's quite a special structure. If you zoom out even more, the back literally attaches the top half of your body to the bottom half of your body. So in order for you to even move and do anything, your back has to be involved. And I think our back goes through changes. And I think when we're younger, you know, obviously we're studying and you know, we have jobs and stuff, but you know, when you're super young, you're playing sports and whatnot, right? Or you're being active, running around, and that physical nature of your back going under physical stress is there. And then I think as we get older, and I'm painting with a broad brush, but I would say the vast majority of us perhaps have more sit-down jobs, or even if we have more labor-intensive jobs, that stress on the back now changes. So the back kind of goes through a lot of different stresses throughout a person's life. So when that happens, it's kind of, I wouldn't say inevitable, but it is very likely for the back to start developing stress when we start letting, maybe it's the wrong term, but letting ourselves go and not being as cognizant of our back muscles and cognizant of our core, and then putting a couple more pounds on. So if you look at it at that 10,000 foot view, I think that's how back pain is such a important and possibly vulnerable spot in our body that just gets bombarded by different stressors as we daily and as we grow and as we change, you know, our lifestyles. And then, you know, the second part of your question is how has it evolved is I think we initially thought of back pain with other pathologies that we think of in medicine, where if something's wrong, you go and you fix it, right? And if a bone's out of place, we got to put it back. Or if a nerve looks like it's being squished, we have to make the hole bigger. I think that logic still holds to a certain extent, but I think what we've learned is there are situations where those procedures are not without risk and are not without a perhaps prolonged recovery. And people have gone in with the best of intentions to try to make the picture or make the spine look perfect. Yet afterwards, patients still have pain. And then now we're in a situation where, well, we scratch our heads as to what happened. We made the picture look good. Why can't we, why does the patient still have pain? And part of the reason why I went into pain was because I think that's quite a cool frontier to be on, is to try to figure out, hey, a lot of these things we can't see on MRI. We can't pick up on nerve conduction studies, but the patient still has pain. How do we go about treating this, you know? So instead of exposing patients who, you know, with aging populations now are older and perhaps, you know, have their admittedly reasonable concerns for undergoing anesthesia for surgery, what other options are there to treat pain that are non-surgical in nature? And that kind of drives innovation, right? And it drives our research and our endeavors on the clinical side of things to try to find new therapies that are less invasive, that can perhaps produce, you know, similar if not superior results to the tried and true or conventional thought process of, hey, let's surgically correct something. So I think there's a role for both, but because of what's happened already, I think medicine's already shifted to try to perhaps zoom out a little bit again and try to see if there's other ways to address things versus just making a picture look as perfect as possible.
And I think I totally agree with you. I think even within the field of surgery itself, they're taking a look at how minimally invasive they can go to try to achieve the same number of results that they can as they were before.
In other specialties, right?
Yeah, absolutely. And it's interesting because it wasn't until I got into pain management, I knew that we know in medical school that the back is a very complicated area, but it wasn't until you start treating everybody with back pain that you just realize where everything can go wrong. Yeah. Everything from what we call anterior column vertebral body pain to middle column, which is the spinal cord and all the nerves, to the posterior column with all the joints and arthritis and everything that could go wrong. So, I mean, it's just that back is so complex that I'm not surprised anymore why it could be a major source of pain for most patients. It's like you said, people abuse it, people don't realize it, and then when you get older, you're like, oh wow, should have taken better care.
Yeah. And I mean, I think we have to say, live your life, right, as a patient, and obviously enjoy life. But like you said, it is quite an elegant structure that has so many things that need to go right, for it to operate correctly. And again, all those aspects, there are potential fault points, and it oftentimes can be things that you didn't do anything wrong. It's just, unfortunately, that wear is a little bit accelerated in one person versus the other. So I think that's important to keep in mind for patients, and also an opportunity for us to, not go through everything from a surgical correctional perspective. If there's other ways to go about it, like you said, multimodal, right? With medications, with therapies.
I just recently had to take care of a slew of patients who were in their 20s with back pain, which is crazy when you think about it.
Yeah.
And it's because they're working out.
Yeah.
They're doing squats.
Yeah.
They're lifting way more than maybe they should, or maybe they're doing what's appropriate, but they're not doing it the right way. Yeah. And they're completely destroying their discs, which is really sad. And luckily we have stuff to help them with that. Yeah. But you've got to take. I mean, they're in their 20s. What's going to happen when they get to 40, 50, 60? Yeah. So it's really sad to see that.
They say it's a young man's game, but it's maybe not even that. And I think if you're going to do that stuff, maybe this goes to that first question, is if you're going to do stuff that puts that much stress, right, on something as important as your low back that you need to take care of for the rest of your life. Yeah. You really got to do it very carefully. You got to think about it before you do, these aggressive movements, because things like that can happen. And, when you're young, sure, you'll recover, right? But we, again, don't know how susceptible, maybe your back's now more susceptible to perhaps accelerated degeneration later on versus someone who didn't do it. So it's always important to work closely, right, with experts and professionals and in those fields to make sure if you're going to do that you do it as safely as you can. And then obviously think about it before you even do it. So changing gears a little bit, like talking about exploring treatment options. Many people think of surgery as the only real fix, right, for back pain. How accurate is that, would you say?
I definitely think it depends on what we're talking about. Because the unfortunate situation is we use the term back pain as this huge all-encompassing term, when in reality, you and I both spoke about how complicated the back structure is and all the different areas that could go wrong. And so I think that it would be a very highly simplified overgeneralization to term back pain and surgery as the fix for back pain as a very, straightforward approach, because not every kind of back pain is created equally. There are definitely situations where surgery needs to be first and foremost. Yeah. You have patients with severe deformative abnormalities of the back, scoliosis, curvature of the spine, things where the structural integrity of the back is at risk. Yeah. People who develop weakness in their legs or in their arms. It could be very dangerous. You don't want to be sitting on that. So these are types of situations where something needs to go in and fix the underlying problem. But here's the thing, pain is a symptom of an underlying problem, as often is thought of in the field of medicine. But sometimes pain becomes the problem itself.
Mm-hmm.
That's the thing that we need to kind of clarify here.
Mm-hmm.
So what happens when you fix weakness? They had pain and they had leg weakness, and it's fixed. They got their strength back. Thankfully, the surgery went well,
Mm-hmm.
but they still have back pain,
Mm-hmm.
or they still have leg pain.
Mm-hmm.
Weakness is improved. What do you do then? Because in that kind of a situation, again, it depends on a lot of factors, but sometimes surgery is not a good option. And the surgeons, additional surgery, for example.
Yeah.
And then you're left with a situation where we want to start exploring what else is out there.
Yeah.
And then there are other situations where surgeons will refer to us saying, hey, what could you do that's a conservative approach for this patient? You want to try to go through all the conservative motions to ensure that we can get the relief that they're looking for and try to avoid surgery. Maybe they're too young and there are implications of that. Maybe they're too old and they have a lot of other what we call comorbidities or other sicknesses that might put them at a higher risk. Because sometimes these surgeries can be a quick recovery, but sometimes these surgeries can be a pretty long recovery and they might not be a good surgical candidate. So they don't want to put them under that stress. So I think that's where it's useful to know that there are other options out there. There are things that we can go from like least invasive to most invasive, right? So if you and I didn't touch on pain psychology, then we've done our patients a disservice, right? Because there are obviously situations where pain, anxiety, depression go hand in hand.
Yeah.
And if you take a patient who is severely depressed, high anxiety, their family depends on them, right? How are they going to be able to serve the needs of the situation? Social issues, right? Marital issues. And you're not addressing those things and you just think, oh, yeah, we can just take care of this. Whether it's surgery or whether it's like an injection or something else, you've done that patient a disservice. And I think sometimes in the world of medicine, we're stressed for time, we're stressed for efficiency, and we don't think about these things. And I think that's why it's important when you come to pain management. And, you and I talk to our patients, we look at the bigger picture and we say, we have a pain psychologist in our group and she's fantastic. And Dr. Weinstein here at USC can teach these patients cognitive behavioral therapy and biofeedback and distraction techniques, ACT, all the stuff that we know can bring like a flare up of pain, at least back down to hopefully baseline levels. We're being realistic. It's not going to be the only thing that helps, but that's important. They need to know these things to help them. And that's just like one aspect, right? And so then, you talk about medications, all the non-opioid stuff that's available now. And then we have procedures that are not necessarily surgical. So we have short procedures, we have injections. I think what you and I try to do when we see a patient is we are trying to figure out where the pain's coming from. I think that's part of what we do. We're sort of putting on our investigator hat. They come in with back pain, and sometimes the surgeons are saying, hey, what do you think about doing an injection at that level or at this level? So that you can figure out, based on the results of this, hey, will they get relief? Is this where the pain's coming from? Sometimes we need to do that ourselves. We need to figure out where the pain's coming from. And, we're talking about back pain, but obviously we take care of all sorts of pain, from head to toe.
Correct.
And just because they're having foot pain or because they're having a headache doesn't necessarily mean that that's it. We've got to figure out why they're having that. And that's where sometimes these injections can help us sort out where the pain's coming from. And we can hone in on and then see, is that the right type of therapy? Do we need to move further into maybe surgery if that's the case for long-term relief? So I think that is another area where I think getting a better understanding of what pain management is also trying to figure out where the pain's coming from. How could you manage the pain if you really don't fully understand where the pain comes from? Sometimes we do, sometimes we can't figure it out. And to the best of our abilities, we've thrown the kitchen sink and we just can't figure it out. But a lot of times we find out where this is coming from, and they may have seen lots of different doctors before us. Right? They've seen lots of different people. And luckily, we're able to hone in and find out where the pain's coming from and then maybe tailor the right treatment path, whether it's surgical or non-surgical.
No, I completely agree. And I think you touched on a super important point is I think, I think this is changing in society and in medicine for the better, is that I think classically the mental aspect of things was kind of discounted, right? I have pain, fix the pain. Like, and it's due to this, do it. Be it an injection or be it a big surgery, just fix it. But if this is a critical thing, obviously, or emergent or urgent, well, we kind of have to move to save life or limb, right? But if it isn't, if there's time, I think it is a disservice to not address the mental aspect of something, right? If someone is not mentally perhaps in the best spot or mentally, optimized, I think you're setting that person up for a suboptimal result or a failure, right, of the procedure or the intervention. And I think, I always talk to my patients saying, we go over, like, we talk to our fellows and we go over like the definition of pain. And the definition of pain is, a nociceptive insult or evidence of a nociceptive insult, but with an emotional or mental component reaction to it, right? So that's half of what pain is. And if you discount half of it, you're kind of fighting with one hand tied behind your back. So I think you're like absolutely right about that. And whether to decide conservative versus non-conservative, I think, I don't know if you agree with me, but it's just talking to the doctors, right? And I think, I'll be honest, this isn't something that's perhaps unique to USC, but I would say at USC, we work with excellent spine surgeons, and they talk to us and we work together very closely all the time about, hey, I think this is the level, but I need your help in trying to see. And we kind of do a diagnostic block per se, right? Or this patient's not, I'm not really sure this patient's a great surgical candidate. Can you help us with this? And I think that kind of teamwork back and forth is invaluable, right?
I totally agree. I think that what's awesome in pain management is the collaborative aspect of the field, because every field in medicine has pain, except for maybe pathology. Let's do it.
Yeah.
But what I'm trying to say is I think every field at some point ends up needing our help.
Yeah.
And it's so great being able to work with so many different kinds of physicians, whether it's the spine surgeons, whether it's OBGYN, general surgeons, they all need our help in figuring out what's the best way to take care of their patient.
Yeah.
So it's been a fantastic ride being able to help and seeing the results that we see.
Yeah.
So what are some non-surgical options available for patients dealing with chronic back pain?
Yeah. I mean, we kind of touched on this a little bit, but I think, there's a big spectrum, right? And it all starts off with the evaluation and kind of, right, they come in with back pain. But like you said, this is such a broad term. People will say sciatica. Sciatica is such a broad term, again. So kind of getting a good understanding about what is going on, what are they feeling, what makes it better, what makes it worse is important an important component to honing in better as to what treatments should be first line, right? But when we're talking about procedures, I get along the spectrum, there's very minimally invasive, very very easy things that we can do, I would say. So, there's things like injections, and even within injections, right, there's things as simple as trigger point injections into the muscle, right? And then if we go a little bit farther down the spectrum to target more specific things, you and I do epidurals in our sleep. It's a very common procedure to try to address pain around the spine that's due to a component of inflammation with the nerves. Along the lines of injections with involvement of needles is blocks that we do, and again, we focus so much on the spine and on back pain, but these are also nerves go everywhere, so we also work in the periphery as well. But in the low back or in the axial spine, we deal most with with these pesky nerves that sense pain from these back joints, right? And moving farther down the line, ablations are a thing where if these blocks do prove to be very beneficial and we want to try to get the patient longer lasting relief, well, we can do very targeted lesions to try to get rid of these pesky pain nerves and try to address the pain while maintaining the function and the strength and the integrity of the spine. Moving farther down, there's things that we do to try to help perhaps augment or adjust the anatomy itself. So we think about thinning out ligaments that are perhaps getting too thick and pushing on the spinal cord and where the nerves run and causing pain through compression there. And then, we go all the way to perhaps the more advanced invasive procedures where, we can do neuromodulation, and we can stimulate nerves, and we can quiet down nerves to try to address pain that way. Or we can, very carefully place catheters to deliver medication in very small but, meaningful amounts right to the spinal cord to help with chronic pain in that sense. And, this is a huge spectrum that I've just kind of, given a quick Reader's Digest view. But I think none of this is, I would say, dangerous. Otherwise, we wouldn't do it. But it's all something that we have to talk to the patient first and tailor.
Exactly.
And I'm sure I've missed a few. Yeah. But a brief, I guess, insight into kind of what we can do from an interventional perspective.
No, I think that was a great overview. I think it's interesting that a lot of patients don't even realize that there's a way of taking care of arthritis of the back by targeting these tiny, tiny little nerves that make you feel the pain from the arthritic joint. Because a lot of people don't think of arthritis as a nerve problem, right? Yeah. But think about it. Take a step back. How do you, as a human being, feel anything?
Nerves.
It's got to be a nerve.
Yeah.
So if you have pain from swollen joints, there's got to be a way of transmitting that pain to the brain, right? Yeah. And we have mapped out where all these tiny, tiny little nerves, and we're still learning. Yeah. We're still learning to this day. We found, in the last 10 years, we found a nerve in the spine called the basivertebral nerve. Correct. And we're able to target that nerve, zap it, and that'll take care of pain from patients who have really bad disc disease and are feeling that bone-on-bone pain from the back. Yeah.
Who previously may have gone for a bigger surgery.
Yeah.
Right? That's a little bit more invasive.
And working with the spine surgeons to maybe even do that procedure before the need for spine surgery so that they get even a better outcome. Yeah. And I think that's what's also great is the fact that, you could work with the spine surgeons to improve outcomes. Yeah. Right? Because it's not
optimized.
Exactly. Yeah. So, and that's the thing. Sometimes people like to, say this or that. Why don't we say this and that? I could eat my cake and eat it too.
That's right.
And so I think we could actually definitely, we do that with a lot of our other surgeons. For example, knee replacement patients, right? We work very closely with the knee surgeons, the orthopedic surgeons who take care of joint replacements of the knee. And sometimes we work on getting their patients better knee pain control through something like radiofrequency ablation. Yep. That way they actually can get a better outcome in their surgery because they don't have as much pain because we've taken care of that component of the pain before they get the knee they get the knee replaced. Yeah. And then now they go through the recovery process, which could be historically very difficult. And it's a lot easier because they don't have as much pain. Yeah. And that's that beauty of working in concert with your referring physicians to just improve everyone's outcome. Yeah. It makes the patients better. It makes the surgeons look good. Yeah. And it makes us feel good. Yeah. And it's a win-win-win situation. Yeah. So absolutely. I think it's really interesting.
Mm-hmm. Yeah. So, I mean, looking at this, we covered very briefly, right? And I'm sure we missed something, but we covered a lot of the things that we can do from an interventional perspective. Probably what people have heard of the most is an epidural. When is an epidural a good option for someone? And what should patients know before considering an epidural?
So let's talk about what an epidural steroid is and what it isn't. I think a lot of people think that an epidural steroid injection is going to cure them of whatever problem it is that they have. And I want to, take that sort of concept down a notch, down to reality. Essentially what an epidural steroid injection is allowing us to place an anti-inflammatory in the form of steroids, maybe some numbing medicine along with it, around an area of the back that is inflamed. That inflammation could be due to a variety of reasons. Most of the time, it's because there's a bulging disc. That bulging disc is sticking out where it shouldn't. It's irritating that nerve. People feel it going down their leg. They're in severe pain. Mm. The thing about an epidural steroid injection is it's not fixing the problem, right? So you still have the bulging disc. You're just reducing the inflammation from what is the main symptom that you're feeling. Now, what you want to think of an epidural steroid injection is a way to be able to do maybe more physical therapy than you could before. Because, we know that physical therapy, if you're trying to look at non-surgical options of fixing this, we know that physical therapy is going to be the best way to be able to get over whatever it is that you're going through, right? So if you can't do that physical therapy because you're in such severe pain, how do you get to do that?
Yeah.
That's where you want to think about an epidural steroid injection, because the epidural steroid injection is not the answer. It's a means to the answer.
Yeah.
So you're able to take that epidural steroid injection, get some relief, which unfortunately is going to be limited. There is no epidural steroid injection I've ever seen in my life by the hands of the most talented physician that will last forever.
Yeah.
That's just the unfortunate thing. So the question is, in that God-given time that you have, whether it's 3 months or 6 months or whatever, what are you going to be able to do with it?
Yeah.
And so you want to educate patients. It's not that I'm going to do this epidural steroid injection. You're going to feel great to be able to sit on the couch and watch your TV.
Yeah.
You want to be able to take that relief that you get for whatever time it's going to be, which you don't know until you actually do it.
Yeah.
And then use that to be able to do more physical therapy, strengthen your core, strengthen your back muscles, strengthen your abdominal muscles and your quads, so that hopefully that bulging disc has the best chance of resorbing on its own. Yeah. And it happens.
Yeah.
It's not like it's impossible. I don't want patients to think that, oh God, I have a bulging disc. I'm going to be, relegated to the rest of my life of having pain unless I have surgery. You have a possibility of that disc improving with time. Yeah. If it doesn't, then at least we can use that epidural to get as much relief as possible to be able to do the restorative stuff in physical therapy. But if they have to have surgery, you can also look at that epidural as a way of ensuring that the surgeons know what level they should be focusing on to get the relief you're looking for. Absolutely. So it works both ways. Yeah. So even if you're going to end up having surgery, a lot of surgeons refer their patients to us for an epidural steroid injection to ensure that's the area that if they operate it on, they're going to have the best source of relief, the best viable odds of recovery. Yeah. So I think that's the best way to look at an epidural steroid injection. It's not the answer, but it is a way of getting either to a surgical answer or to be able to do more physical therapy than they could before. Yeah.
I feel like I hear, I've done epidurals and the patients will be like, oh my gosh, you cured me. Or so-and-so cured me with an epidural. My response is always, no, you cured yourself, because an epidural, again, is not meant to last forever. If it lasts forever, it's not because the epidural did. It's because we broke the cycle to the point where you and your body and your hard work can figure things out and let the body kind of do its own rehabilitation, essentially. And I feel like a lot of patients get into this cycle, right, where it hurts, so they don't want to do anything. But they have to do something to make it hurt less. Or there's too much inflammation going on to where if they try to move more, it's just too painful. And it makes them not want to move, not want to move even more, which makes their pain even worse, or it makes their recovery even slower. So I think an epidural is a nice way to hopefully break that cycle, right? And to give this window of opportunity where you really can make meaningful progress through physical therapy means, or maybe, with the help of some medication, to really give this window to allow your body to try to, again, restore itself to a certain extent. And if it doesn't happen, and if the pathology is too much, well, again, it's at least like the canary in the coal mine that tells you, hey, here, this is the area, so that us surgeons, whoever, can go in with a little bit more confidence, to present a surgical option, essentially.
Absolutely. I think it's also sad sometimes to see that, unfortunately, and you and I have both seen it, we've seen patients where they come from other providers where it's epidural steroid, epidural steroid, epidural steroid, epidural steroid. It's almost like an abusive situation where, the first epidural helped for, 3 to 6 months. The next epidural helped for 2 months. The next epidural for 1 month. Then they're doing an epidural every 2 weeks. This is not, I mean, that's why, unfortunately, we're seeing backlash from insurance companies in terms of approving these types of things, because that's not the right way to be thinking about how epidural steroid injections are supposed to go. Yeah. We are looking for long-term relief. Yeah. And so, how are we able to do that? Yeah. If an epidural is not the right thing, if it's losing its efficacy, we got to think of something different.
Yeah.
So it's this whole idea of not beating a dead horse here.
Yeah, that's something I think our group really focuses on preaching to our patients is we don't want patients to think like, oh, this is how I live now. Every 3 months or every week, God forbid it's every week, but every month or something, right? You have to go for your epidural. And I think that's a situation where you're putting a Band-Aid on something.
Exactly.
And you're not kind of addressing the source, essentially.
Yeah. So Alex, at USC, how's pain management approached differently? I mean, what makes the care here unique, or maybe even what people would say more intentional?
Yeah, I mean, I would say, and again, this might be zooming out a little bit, but I would say the answer to this is also a big reason why I stayed. I trained here, and I think that USC fosters an amazing culture, at least for us physicians to work in. And I think that kind of translates to patient care. I think pain management is perhaps, like we discussed earlier, something that a lot of people don't know about. But once you know about them, it's almost like it's like you see something and then you kind of zoom out and you actually see that they're everywhere. I think you have a lot of options, right? And there are a lot of pain groups out there. But I think what's different about us is, we try to get an answer the best we can. And what I mean by that is, there are groups, other types of practices out there that I'm sure do a great job in pain. But what I think we try to do is we try not to get stuck. We try not to repeat something that perhaps worked amazingly, but now is not working as well, and then isn't even working less well. And we just say, well, that's that, right? And we're just going to keep doing this one thing. So I think we touched base earlier on epidurals. If an epidural lasts, let's say 4 months, amazing, right? But then the next one lasts 2, and then it lasts 1. Well, I don't think we for sure are not a group that will keep doing that, right? We will try to zoom out and we'll take another look and we'll look at all the other amazing interventions that we have here at our pain group at USC to try to see if we can provide another therapy that can provide a better, longer lasting result. And I think we touch base on interventions, right? But this thought process extends, right, to not just interventions and injections and stimulators and whatnot, but it's also to medications too. It's not just, oh, well, this is it. You're just going to stay on this forever, right? I think, at least in my clinic, I always tell people, hey, we give this a good 1 to 2 months, right? Because annoyingly, some pain medicines take that long to build a state until we can get a good answer. But if this isn't doing well, we stop and we switch and we pivot and we adjust. And I think some patients find that a little bit annoying because they think we keep changing the plan. But I think afterwards they come back and they see that we're not trying to continuously fit a circle block into a square hole. We have to adjust to try to find the answer. And I think here at USC, we try to do that always. We really give it as aggressive as a shot as possible to get down to brass tacks and get the right answer for you.
You hit the nail on the head, Alex, I think, when you said taking the best possible approach, because at USC, I feel like there's very little we don't do.
Yeah.
In the field of pain management, there are some limitations at some pain management groups. They just don't do certain things. But at USC, the pain management group here, we do just about everything.
Yeah.
There's very little that we don't do.
Yeah.
And I think because of that, we think outside the box more often.
Yeah.
And I think that in patients who may have been to other pain management physicians or are coming from the outside and don't know what to expect, I think they're pleasantly surprised by just how much we're able to offer them.
Yeah.
And I also think that at USC, because a lot of patients come from outside of USC and don't know what options might exist, even if pain management is not the ultimate option, we're able to provide them or connect them to the broader USC community if it's appropriate, and tell them, hey, maybe getting a second opinion from somebody else.
Yeah.
So the fact that we can offer as much as we can within the pain management group is pretty exceptional.
Yeah.
I think that there's like I said, bar none, just about everything.
Yeah.
And if it can't fit within that, we can link them up to the right people.
Yeah.
I think that's really the ultimate thing.
Yeah.
So I 100% agree with you.
Yeah. And I'll even touch base more, because I think, people will look at this and they'll be like, well, what about the things you don't do? And obviously those things exist, but I agree with you. We do pretty much everything. But I think what is also unique about our group is we also don't jump at the newest shiny thing. We adopt the most advanced therapies when they're appropriate. So you and I have sat and we've talked and we've debated about whether or not to bring a therapy on, because we care. We don't want to just say, oh, this is new, we'll do it. We really scratch our heads a little bit and we talk to all our partners and everyone in the division to make sure that this is the right thing. So
what's the best evidence?
Correct, exactly. And then if it's in our broad portfolio, I would say it's been vetted. Like, we've really looked at this to make sure that this is a safe and effective thing for the right patient, for the right diagnosis.
Right. Well, thanks so much for joining us. Hopefully you learned a lot, and I hope you get to come and join us for part 2, where we're going to have a further discussion about what other options exist in pain management.